Hello and welcome to Sheila Lives Out Loud. My name is Sheila Moniga. Thank you so much for catching up with me on this channel. As always, please click subscribe and hit notifications so you never miss an episode. And while we're still counting down to season 8 of this YouTube channel, we are stepping in with the times and keeping you abreast with information concerning the coronavirus and COVID-19 in Kenya. And joining me for a conversation is Professor Reena Shah, the Section Head of Infectious Diseases and the Fellowship Director for Infectious Disease Fellowship Program at Aga Khan University. Currently, she's also the lead HIV clinician for HIV services at Aga Khan University Hospital, Nairobi, Kenya. And nationally, she is the Vice Chair of the HIV Clinician Society of Kenya and is also the Vice Chair of the Kenya Sepsis Alliance and an executive member of the Infectious Diseases Society of Kenya. Professor Shah, it is such a wonderful honor to be in your presence, virtually, of course, but thank you for making the time for this conversation.
Thank you, Sheila.
As we begin, we are past washing hands. It's about having more in-depth knowledge because everything is mutating and changing by the week. And I think information programs and awareness programs in Kenya have been quite good. I think everybody knows about social distancing and how we should be washing our hands and why it's very important. But I'd like us to go in depth into understanding what happens to a human's body after exposure to the coronavirus. I'd like us to walk through that amongst a few other issues that are placed on the table. So let's begin with when that virus comes into contact with your mucous membrane, because we know to stay away from it. But for some people, that is not going to happen. So what happens once exposure has begun?
So if you're exposed to the coronavirus, and as you said earlier, that it's through contact, right? So either you breathe it because somebody is coughing or sneezing near you, or you touch something, you touch a surface that has the virus, and it touches you touch your mouth or your nose, and it enters your mucous membranes. What would happen is one of three things. One is that it doesn't enter your mucous membranes. You can touch your mucous membranes, and your mucous membranes are your first line of defense. So it doesn't enter it. Okay, so not everybody who has virus entering the touching the mucous membranes will enter. So it doesn't enter. Mm-hmm. The second thing is it enters, and your body's immune system is so good, it gets rid of it. Our mucous membranes are very good. It's our first line of defense, the first soldier. Mm-hmm. If it were to enter the mucous membranes, then we have what we call our own immunity that takes play. So our immunity tries and attacks the virus. Mm-hmm. And depending on whether it's successful or not, it depends on your type of immunity, on whether it can get rid of it or not. Mm-hmm. So if it gets rid of it, that's it, it's done. Or it can enter the mucous membranes, and then still your blood and your other defenses go into play, and you get what we call mild symptoms. And as the mild symptoms are happening, your immunity is also at play, trying to get rid of the virus. So those people get mild infection. So you get a few days of infection and you get better. Right? Like the flu, the normal flu we get, we're unwell for a few days and we get better. But if it overcomes your immune system, then the virus goes into your lungs and causes all the moderate and severe symptoms that we're reading about in the news.
All right. Thank you for explaining that, because that helps me understand why last week we heard Prince Charles was COVID positive. And then this week he says he's fine. The big question for a lot of people was, how do you go from being positive to you're okay in less than 10 days. But I think a lot of people, it's fueled by knowing that this thing has no way of being beaten. However, it's not everybody who comes into contact with the coronavirus that actually develops COVID-19.
Absolutely correct. I think they say 80 to 85% of patients who get the coronavirus recover. Okay. So it's the 15 to the 20% of patients, of all patients who get coronavirus, that get moderate to severe symptoms. And out of that is the 5% that get the severe illness and end up in ICU.
All right.
The reason we're doing the social distance, is to reduce the number. We want, if we have 15% of 100 is a lot easier to manage than 15% of 100,000.
Right.
And that's why we're doing social distancing, to reduce the total number that get infected.
Okay. Now, In the case of the 15%, I'd like us to focus on that. Yesterday, we had great news in Kenya about 2 patients who are better and are resuming their normal lives. But we'd like to understand what their journey has been like. And I think that now speaks to the 15%. Once the virus has passed through the first line of defense, has gone through the second line of defense, what's happening to the body, say, in days 1 to days 4, and then from days 5 to, say, 10, and so on?
So from once infection has happened, once you've gotten infected, and it's past your mucous membranes, first day 1 to 4, the body is trying to fight it, so it doesn't go any deeper. Right, you don't want it to go into the lungs, or you want minimal amount to go into the lungs. So that's day 1 to 4. After that, once it's in the lungs, it goes and infects the lungs, and when it infecting the lungs, it prevents gas exchange. As we know, basic biology, we breathe in oxygen and breathe out carbon dioxide. Now, if it's affecting the lungs and making them what we call stiff, and not allowing them to go through the gas exchange, your body is not able to maintain its oxygen saturation. Your oxygen saturation needs to be at about 92%. So if I were to do my blood test or yours and look at an oxygen saturation, we're at about 90% plus. But if the gas exchange cannot happen and you cannot breathe in adequate oxygen, your oxygen level goes down. And that's when you need what we call supplement oxygen. And that's why you see all these pictures of patients with COVID having oxygen initially. Mm-hmm. Then as it infects more, your body is fighting it, it's fighting it, causing what we call inflammation, causing swelling of the lungs. So when that's happening, you're not able to exchange gases more. You cannot even maintain your oxygenation with supplement oxygen. Mm-hmm. So after that, days 5 to 8 to 10 is when that's not happening. You end up having to use a ventilator. Of course, as doctors, we monitor that. So we monitor patients who come in, we put them on oxygen, and hopefully that is enough. Mm-hmm. So we're doing the oxygen saturations regularly. But as we see the saturation going down, even on oxygen, then we have to make a decision on ventilating the patient. Mm-hmm. What we mean by ventilation is we're actually artificially taking over the function of the lung to maintain that gas exchange, to maintain oxygen. As we know, we need oxygen in the body for all our cell functions, for our brain to function, for our kidney to function. So if we don't maintain that, all that shuts down. Mm-hmm. And that's the process. Having said that, not everybody who's put on oxygen goes onto a ventilator. Right. There are a lot of patients who are on just the wards or put on oxygen. We're supporting the lungs, helping them, and they get better. So not everybody who's put on oxygen ends up with a ventilator, but in the worst case scenario, that's a progression.
Okay. The big question on everybody's mouths today is chances of reinfection. Once you've gone through all the stages, you've been strong enough to fight it, and you're thinking about living a normal life, is it possible to still be exposed to, say, a different individual who's got the virus, and then you go through the cycle again? Is that a possibility? Or is it just like any other flu? Once you've gone through it, you've built your antibodies and you're good to go?
So that's $1 million question. The correct answer is we really don't know. Right. We're hoping that it helps us build immunity, but we don't know. There have been cases of reinfection in China. Mm-hmm. But to be honest, we don't know. We know it's like the normal influenza that the virus does mutate, and every year or every 2 years there's a different strain. And that's why every year you have a different influenza vaccine. Mm-hmm. So I'm assuming it may follow that. But for this particular strain, we're hoping that there's going to be some immunity.
Okay. Now, looking at the work that you've done, you've worked with HIV patients, and when it comes to TB, you're an absolute specialist. And I'm thinking, COVID is pneumonia. The lungs are really severely affected. For those patients that do get better, is there any kind of long-term lung damage, or do the lungs completely recover and heal, and there's no sign that there was ever any pandemonium with COVID?
So we think that for majority of patients who have mild to moderate symptoms with corona will not have any long-term side effects with the lung. Okay. But the worry is the patients who end up getting ventilated in ICUs. We're worried that those are the people that may have long-term implications. How much there is, time will tell. We really don't know. We're watching that space. But we're actually hoping that not so many of our patients end up going to ICU. And if that happens, then probably not.
All right. There've
But
been
it's watch that space. I think we'll only know in the next 6 to 12 months
right.
the effect on the lungs.
I suppose you'll be checking a lot of the people who recovered and studying.
Correct.
From those who
Yes.
sadly will have moved on. But I'd like us to talk about comorbidity, because there's so many new expressions, Professor, that we're all now using as part of our new normal. We've talked about social distancing and we've talked about quarantine, but I'd like us to talk about comorbidity. And I think this is also one of those things that's very in line with your specialties, because living in Kenya, living in Africa, HIV, TB, those are very big diseases and they account for quite a number of deaths every year. And these people are at more higher risk when it comes to the coronavirus. Why is that? In fact, I think what is comorbidity?
Yes. So comorbidities is having another condition. So you can be well and going with your normal daily life, but you can have other illnesses, like you mentioned, HIV. You can have diabetes, renal dysfunction, cardiac disease. So those are comorbidities. So people living with conditions other than coronavirus.
Mm-hmm.
And then if you have those conditions and you get coronavirus, it's like getting a double hit. From studies abroad, from China, Italy, UK, US, we find that patients who have diabetes, heart failure, seem to have worse disease than the people who do not have. So if you take a 50-year-old individual who's got no comorbidities and has diabetes, we find that a patient who has diabetes has severe form of the coronavirus.
Mm-hmm.
Now, the million-dollar question is, here in Africa, we are the epidemic of HIV. We have majority of the HIV patients are here in sub-Saharan Africa. How is this disease going to play with us here? We don't know yet, because we're in the early stages, what we call the early stages of the epidemic. Mm-hmm. Italy is in the mature form of the epidemic. China is past the epidemic. So we have different phases of epidemic. Mm-hmm. So this is early. So my advice is, if you do have a comorbid condition, whether it's diabetes, whether it's HIV, you've got to be very careful. I mean, the social distancing should probably go a bit beyond that into social isolation for the next few weeks. Mm-hmm. I tell my patients and my friends, really look after yourself, because you are more at risk of not only getting the coronavirus, but getting a more severe form of the virus.
Mm-hmm. Mm-hmm. All right. Thank you so much for helping me understand that. Now, before we wind up, I've got about 2 or 3 more questions for you. And I'll start with a question that people have been discussing, especially when it comes to kitting their first aid boxes in the house. There have been questions about what tablets to put in there for just in case. And there's a conversation about ibuprofen versus paracetamol. And what we're reading or hearing is ibuprofen is not exactly your first port of defense when it comes to sorting out pains and issues, if at all you've been exposed to coronavirus. So why is that? Or is there truth in that?
So there is currently no evidence, but just to give you a little bit of historical reasoning behind that, is that there's some studies that showed in the lab, not on patients, that if you take ibuprofen, it increases your ACE inhibitors. That's a receptor, mm-hmm. which the virus uses to get into your body.
Okay.
So they're saying that if you use ibuprofen, it increases your ACE inhibitors and you're more likely to get the infection. There's been really no evidence to that. So currently, no medical organization is saying don't use that. Okay. So I think it's a little bit of a myth. But if you want to be absolutely careful, as you know, it's a new virus, we don't have all the data. Yeah. I mean, if you can use an alternative, it's fine, but there is no evidence saying do not use ibuprofen.
All right. Thank you so much for clarifying that, because when it comes to misconceptions, there are so many everywhere, because
so many
who are saying this is not going to affect me because I'm young, I'm 18, I'm 21, and I am not 50 and I'm not 60. One thing I really need you to stress on is it looks at more than just age, Doc.
Correct. And if I look at the data that's coming from the UK and the US, I mean, the UK had the youngest death. It was a 13-year-old boy who had no comorbids. So that's taught us a lot of things, that is the virus mutating? We don't know. Or does it behave differently in different populations? We don't know. So I think it's a myth. I think it's affecting everybody. A lot of the ICUs in the West have between 30 to 50-year-olds. So don't just think that if you're young and you don't have another infection, you're okay. You're not.
Yeah,
You've got
don't
to be
take
very
it for
careful.
granted. Now, looking at the treatment
Correct.
protocol, in some countries, I was reading about a 42-year-old woman who had the disease, and she was on a Yale study, and I think it was a Yale trial, and they were using hydroxychloroquine. Is that the protocol that we're using in Kenya, or is there a different kind of protocol at play?
So, we're not using it in all patients. We're using it in the patients who are have severe coronavirus, so the patients who are admitted or
Yeah.
in critical care areas. Having said that, there is still no evidence it helps.
Mhm.
The only probably reason we can use it is it's a drug that's available to us. It's not one of those big trial drugs like remdesivir or else, which we don't have here. So if
Right.
we look at the drugs that have shown to work, it's the only one we have here. Having said that, there is no evidence it works. A lot of us don't believe it works, but because that's the only thing there, it is being used. But having said that, do
Yeah.
not use it. I want people to know that they cannot use it as prophylaxis.
Mhm.
I think there was a time that we just ran out of the drug in the country because everyone went and bought it.
Yes.
It's not as simple as that. And it's a very important drug for people with rheumatoid arthritis. So if it sells out, the people who really need it do not get it. So for now, it's not recommended as prophylaxis. It's not recommended for people who have mild and moderate symptoms. It's in the West, even it's just being used in trials. A lot of countries are all still not using it. So
Mhm.
it's not like it's the panacea for COVID. It isn't. We're not sure. And the amount it's being used in the West, we're still having a lot of mortalities. It tells us it's not probably going to work as we believe that it's the magic drug. It's not.
Okay, so stop walking around like you're invincible and thinking that chloroquine is there and you're in Africa and you've got it.
Correct.
Okay, I'd like us to talk about herd immunity. And I heard about this expression after I watched a documentary about Sweden where they didn't lock down, where life continues as normal. And you don't even have to go to Europe to see that. Tanzania, our very own neighbor, I think for them, life has gone on as it was before. So this thing called herd immunity, help us understand what it means and does it really work?
So I'll tell you about herd immunity. Herd immunity is when a whole population gets immune. So for example, if you take a disease like measles,
Yeah.
right? When people are vaccinated, if the whole population is vaccinated against measles, there's immunity. Now, suddenly, if as we saw in Europe and America last year, a lot of parents stopped getting their children immunized. Suddenly, there was an outbreak of measles. So that's a part of immunity. Immunity is your body ability to fight an infection. Chicken pox is the one that, when we have children, we want our children to get chicken pox so that they get immunity, so they don't get it as they grow older. So there's certain diseases where immunity works, right? So if you get exposure, you get immunity, and then you don't get the disease again.
Mhm.
It doesn't work in certain diseases. The main one, if I look at HIV, there is no herd immunity. You have the antibodies, but the antibodies don't prevent progression of the illness. So there's been lots of to and fro of herd immunity. England initially went that way and said we should do herd immunity, let everybody go out. The more the population gets immune, we may not get the virus again. What we don't know yet is whether that's going to work. Again, that time will tell us. But the reason countries in the West have gone into lockdown or quarantine or reduced or social distancing is to prevent the surge. So even though you may be getting immunity at a low level, if you get the surge of people getting infected, your healthcare services will not be able to manage them. And when that happens, you have a high mortality. So in terms of whether the jury is out in herd immunity in coronavirus, we don't know, right? But if I were to get the infection today, like I said, three things can happen. I can be asymptomatic, not have any symptoms. I can get mild disease and recover, or I can die. I don't know which of those three I'm going to fall under because we know currently there is no immunity. It's a new virus. What we will know is by next year how well the immunity is working. But for the current situation, we cannot work on the herd immunity. Current situation, we have to social distance and reduce the surge so that our healthcare services can manage those few people who do get the virus for now.
Right. So in closing, there's so much that you can put on the table, especially in terms of caring for the health workers, because you're all in the front line. I think for most of us, if we stay home and follow the instructions, we should be okay. But you can't stay home. You can't social distance. You've got to be out there with the patients. How can we help you? As the Kenyan people, as just human beings, what can we do, Doc? Because feeling helpless
You could
is such
stay
a
at
bad
home to
emotion.
the more of you that stay home, the more of you that social distance, you will save us, because less of you will come to us and we will have less exposure. We can't stay at home. We're emergency services. So we can't stay at home. But those of you who can stay home, please stay home for the next few weeks. I mean, it's not indefinite. It's next few weeks during your home. There are times I wish I could be at home with my family and I can't. For
Yeah.
those of you who can, just do it. Stay there, stay at home.
Okay. One more quick question dealing with healthcare workers and masks, because I'm seeing people walking around with all kinds of things on their faces. Masks, do they really help us out here, or should we just be giving the masks to health workers?
So for health workers should have masks. I mean, there is no question about that. Who in the general public should have masks? If you ask me, it's people who have symptoms. So if you're symptomatic, you should wear a mask. If you've had a contact with somebody who's symptomatic, you should wear masks. Having said that, it's not an easy thing. I don't know if you've ever worn a mask,
No, I
but to
just
sit
bought
and wear
gloves
it
at
for
the
12.
supermarket the other day, and I thought my hands were going to fall off and might leave my body.
Correct. So even wearing masks is an art. You've got to wear it correctly. There's a way of wearing it, and there's a right type of mask. The surgical mask, for example, we know it doesn't work after 3 hours because the moisture gets into it, and once it gets wet or moist, it doesn't work. It will let germs in and let germs out. So there's guidelines on wearing masks. So yes, people wear masks. I mean, but it shouldn't give you a false sense of security.
Okay.
The most important thing is social distancing and washing your hands. Those are the two things that will really save you in this epidemic.
Fantastic. Thank you so much, Prof. I am so thankful for the time you spent sharing this information. The doors remain open. If there's anything you'd like to say any time of the day, please give me a call and I'll only be happy to share the information.
Okay, thank you, and you're welcome. Thank you.
Thank you very much. And thank you for watching this episode. Remember to stay safe, listen to the good doctor's advice. Thank you so much to Professor Shah for sharing that information with us. Remember to click subscribe and hit notifications. And let's keep each other safe. Until our next episode, live out loud in all that you do. Bye for now.